Okay, thank you very much, everyone. We're going to start what I'm hoping will be quite a lively discussion amongst the surgical experts on the panel. Obviously, surgery is not possible, sadly, for many patients, but it is, the route to cure for that small number of patients, and this is a really key question. So please feel free to come with your questions to the panel. We'd like to open it to the floor to start off, and please submit questions online as well. So, do we have a question?
I have a question to Professor Stephen. My name is Katrina. I'm coming from Ireland. I had a biliary drainage inserted last August, and you were saying that it's better not to drain. But basically what happened with me, after they inserted the drainage and 24 hours later surgery team decided to clamp it, it just caused extreme pain, and basically I had to demand to reopen it. And that helped, but they kept clamp it, and I was getting infection after infection, and that was going on for almost 3 months. I spent 3 months in hospital on, multiply antibiotics, IV antibiotics, and different types of infection, from one to the other. Eventually, when I was transferred to hepatology team, they decided to keep it open, and since then, I haven't got even one infection. I went abroad as well for a second opinion, and I heard the same, keep it open to drain it. And as I said, since then I don't have any infection, I don't have any problems. So I'm just wondering, because you're saying, don't drain.
So could we maybe have some response from each member of the
sure,
panel? So perhaps we could start at the front, Dr. Tupan.
Oh, sorry.
So if each of you could just perhaps clarify who you would drain, who you wouldn't drain, and the question about sepsis. So each of you in turn, please just give me your comments.
Oh, but first to answer your question, if that's okay, Chairperson.
Could you not just, in your answer to the question, just let's take it round the table one at a time, please. Please.
Okay, for the question is involving preoperative drainage, because in my routine practice, I drain every case that present with jaundice, because I think it's improved. It can treat the cholangitis. It improve the patient symptom, reduce pain, improve the liver remnant functions. So I refer to drain every case. Okay.
John?
So, anyone who says that drainage is straightforward and never has problems is deluded. We all have problems. Just to look at the patients who are going to have surgery, our choice at the moment is to drain externally with no passing of the tumour, and certainly not into the gut, and that's how we do it. And we, as I've said before at this meeting, we get patients to recycle the bile by drinking it, which some people find objectionable, but it actually works pretty well, particularly if you put it in Guinness, because it's two horrible tastes together are sort of counteract each other. I think my view is the problem is the gut. Once you transgress a tumour and go with your catheter into the gut, you're going to get infection. And that's why I find the proposal that Baz has made in the Tesla trial actually is something we should all be exploring. And I'm trying to get our own radiologists to do that, because I think that is a potential advance.
Steve?
So you were drained after the resection, wasn't it? Or was it the question, if I listened to you carefully, it was before before or after the resection?
No, the first, basically, I was diagnosed with PSC, and then, basically they said, because, I had joints and everything, so they decided to insert the drainage.
Yeah.
But as I said, then they said, no, the liver gonna start work itself, so they kind of kept closing it. But it's just caused more problems than actually.
Yeah. So the carcinoma, the best way to treat it, or the only way, is R0 resection. So you need to do a huge operation. For a good operation, you need at least a sterile liver. So no contamination with GI tract bacteria. That's the reason that we try to avoid drainage. If you need to drain, and there are some people that you need to drain, and they have an infection when they arrive at us, so they already have a cholangitis. They have a very small remnant liver, so you want to grow the liver. There we drain and do a procedure to make it grow, portal-venous embolization and double vein embolization. And then we do the stenting in which we do not pass the ampulla. In your case, when you have to drain, and even if we drain, it's very important that the enterohepatic cycle is established, because the bile acids are also activators of hormonal systems that we need for liver resection. So this is a very tight, regulated system. So in case we can avoid, and the debate is still not closed, we think you need 40% remnant liver, 35%, sterile environment. There we think that you can go very quickly within a week to operation without doing a Tesla stent, because we also lost one patient in Maastricht in the preoperative setting for Tesla stenting because of complications. So that patient never went into an operation, although the first 4 or 5 that we did were successful. And that is also a plea for a good registration, what we're doing, because we're very bad in registration. We look what we like to look at. We do big operations and we only have 10% mortality.
Steve, quite a long response. We've got a lot of topics that I want to cover,
Good.
so can we move on?
Yeah.
Christoph, please, you've talked about the quality of intervention and regionalising specialist centres to ensure adequate biliary drainage. Any other comments on where or how or who should be providing the drainage service?
So yes, we will also centralize these drainage procedures to the 4 university hospitals. We are usually copying everything the Dutch do. So we would stent the way they do, and we will read what they write with their much larger population and much larger experience. But my question is to Steve also, do you do the Tesla technique with not passing the papilla and putting in a self-expandable stent also for patients on their way to resection? Yeah.
Okay, I'm keen for us to go over other topics, but please carry on. I'd rather we don't revisit biliary drainage, because I think you've heard the panel's view on that, and we are keen to discuss other topics. But if it's on another topic, please carry on.
It's another topic. I want to talk about the pump. So I'm a medical oncologist in Dublin, and really Tom Cash is a great study and brilliant to see what you're doing in a very small country. But John, we have a number of patients, and I'm really glad everybody has brought up this liver-confined intrahepatic cholangiocarcinomas that we see. Unresectable up front, we know combination local regional therapies, including Y90 and systemic therapies, really provide a huge opportunity for us to downstage those patients. But many of the patients that I see in Dublin are going for second opinions to the US and North America. And everyone will provide them with a pump if someone can look after the pump back in Ireland or the UK. So the Netherlands have been able to do it, Norway's doing it. So how can we work together in the UK and in Ireland to really look at this inability to provide FUDR to our patients and provide a large European trial for pump therapy? Because I think it's really very much needed. So perhaps, John, what your thoughts might be first.
Well, I think the way forward is that there's a large company has taken over the pump company, and there is a possibility that they could get the FUDR license in Europe. So I think we've got to have industry support for this. Otherwise, it's not going to happen. Because at the moment, you can only use it in a trial. So that's the first problem to overcome. I mean, the FUDR has to be available, and then who's going to pay for the pump? I mean, as you say, patients are going to the USA and being charged vast amounts of money to have the pump inserted, and it's not cheap. I mean, the preferred way of doing it is to use a robot. Not everybody has a robot, but the dissection is not dissimilar, I think, to when you're doing a Whipple's, isn't it, really? I mean, I've not done it, but it's the same exposure of the hepatic artery. So this is not a minor intervention. There's that the skill set will have to develop to do it across Europe. You presumably you do it with the robot, do you? Yeah. So there's a number of barriers, but I think the fact that the pump company has been taken over by a larger company, there probably is a potential to see that in the UK as well as the rest of Europe.
Could you maybe just clarify for us? I think everybody would be interested in your view on how you would select appropriate patients for pump therapy.
I'm glad you asked that. I'm a medical oncologist who researches molecular profiling. So, I mean, there are patients who do not want to move outside the liver. We can understand those by the genotype, immunophenotype interactions. That's an ongoing paralleling process in terms of research. But I think, there are opportunities in terms of that molecular profile, potentially induction chemotherapy, especially with Y90, to really look at those patients, which is why I think TOMCAT is very important. But I think together we should be able to go to these companies to design clinical trials with valuable endpoints and translational endpoints so we can learn, because every patient should be offered.
Specifically, the question was, how would you select the patients? What group are you looking for?
Liver confined,
obviously. Liver-limited disease, refractory to first or second line therapy, where would it be in the algorithm for treatment?
Absolutely, sorry. Yes, so I would absolutely select after first line therapy, because then you've already biologically selected patients who have remained liver confined. And then you can perhaps integrate some translational endpoints into that. But I wouldn't go beyond, after first line, I would look at that second line population. I wouldn't go to third line.
Okay, any of the panel want to comment on that response? Please.
Yeah, I would like to comment that we learned from the CIRCA study. So the liver defined, so in the PUMP2 study, we actually were much broader than the CIRCA study, because we do know that the lymph nodes are enlarged in the disease anyway, and we do not know if they all are having metastasis at all. So we should be aware that the inclusion criteria for the pump is broader than just liver defined. That's one thing. And the other thing is, what we learned from the pump as well is that we allowed patients to have had systemic treatment before. So what we did is, for example, FGFR2 fusion, to have systemic treatment even in a clinical trial before, and when failure, going to local treatment as well. So I think we need to play, especially in a rare disease, with options.
Yep.
Christoph?
I just want to add that you're perfectly suited in the UK and Ireland and in Holland for a pump program. Norway is the worst country to start it up, because they have to come in every fortnight to refill the pump, and many of them have to fly.
It's a problem. Yep.
Okay, thank you very much indeed. I think we should move on. That's a very useful question indeed. Please.
Juan Vale, Cholangiocarcinoma Foundation from the US. Surgical decision-making largely is based on size and location of the tumors, but we know biology is king. And we now know, for example, that having a KRAS mutation gives you an adverse prognosis, and this is more likely in liver fluke-associated FGFR fusions are associated with a favorable prognosis. So what was the panel's thoughts on integrating the biology of what we're learning of cholangiocarcinoma into the surgical decision-making?
Or maybe direct this to Christopher, if you're doing targetable testing for all your patients.
Yes, I think we'll have kind of a John's oncological view on it, but we have managed to turn around the country and make sure that everybody gets an upfront panel now if they're at any way receptible for tumor-directed treatment. I must admit that we still don't know a lot about what to do with it, with the results, but we have the results and we can at least look into what prognostic value they have for today's standard treatment. Many of the targeted treatments that were mentioned by John are not available in Norway. They are approved but not funded.
Can I turn the question back to you? If you got a favourable molecular profile on somebody that was resectable, would you offer them first-line targeted therapy?
Well, I think
Obviously, it would be your MDT discussion,
Yeah.
but would you support that?
I'm not sure we're ready for that yet at the moment. You know, the preoperative therapies that have been successful in other cancers have really been associated with very high response rates, and the response rate we're currently seeing are rather on the low side. We're now seeing a generational change, for example, with the FGFR inhibitors, with responses getting towards 40, and in the newest inhibitors, 70%. So once we're getting to those stages where we know these therapies are very, very effective, then it makes it much more attractive to bring it into that setting.
So, any of the surgical panel against the concept of downstaging or neoadjuvant with immunotherapies for appropriately targetable patients?
Well, I think the issue, Juan, is for intrahepatic, it's not so difficult. You can take a bit of tissue. Perihilas we normally operate on without histological confirmation because it's difficult to get. And I don't know whether you do anything differently. You do get hit. No. So for perihilar disease, I think it's difficult to get histology, let alone a profile. So I think at the moment, I think you've just got to forget that. Maybe circulating markers might provide the answer, but it's not going to be sticking a scope up into the bile duct because that's just catastrophic. So intrahepatic, I guess we think about it, but then you're subjecting a patient to an invasive procedure as well to get a profile, and I think you'd have to consider the risks and the benefits.
Christoph?
I just think that we need to make sure we don't misunderstand each other, because if you have an unresectable situation, you do whatever it takes. Just see if you can convert it. So when we say neoadjuvant, we need to be very strict on that. That means a directly resectable case that for some reason you will try to reduce the risk of recurrence.
I think, Heinz, you want to come back in?
Yeah, I would like to answer the question of Juan in the way that with the NeoDisco study, which we do in neoadjuvantly for perihilar and distal carcinomas in the Netherlands, we thought if you do not respond well, we turn it around. If you do not respond well, you will not have a unnecessary resection. So we are aware of that. The response rate, of course, is not as high as we wish for, but we at least do not treat patients with an operation up front if they have a bad mutational load. But it's a randomized controlled trial, so we will see if that is beneficial for the patient overall. But I guess that's kind of answer to your question.
But with a lot of debate, we are also part of the NeoDisco because we apparently will probably also lose patients in the 24 months that we treat them, and that they progress and that because they were upfront resectable.
Okay, thank you very much indeed. Shahid, I thought you had plenty of opportunity of chatting earlier.
Well, it's great to see so many HPB surgeons in one place, all complementing each other. Very rare to see that.
We're all nice people. That's the thing. We're misunderstood.
So my question was, we've had a lot of discussion about patient selection. My question was flipping that about surgeon selection. So if we're going to talk about the possibility of centres of expertise who is or isn't allowed to operate on this, would we able, in the UK at least, even, to get consensus on who is and isn't allowed to operate on perihilar cancers? How would we achieve that? Should we have almost like transplant, a sort of national MDT that decides who's going to do it? And how easy is that going to be to sell?
Okay, not a controversial topic at all. Please, can we go around the panel, please? So, Atpal, how do you decide who operates for cholangiocarcinoma?
I think it depends on the experience of the surgeon and experience of the center, because if the center is low volume of perihilar cholangiocarcinoma, they is not keen to do the surgery for perihilar cholangiocarcinoma. Should be referred to a high experience center. And
okay, John, do you verify who's appropriate in-house or externally assessed?
So it's simple. We do it in-house. There are 7 of us now. 3 of us do all the hilers, and we do it virtually always with two consultants. That's what we do.
Thanks, Steve.
Yeah, that's the same system in the Netherlands. I think it's beneficial when you don't have a private practice system in your country. And there's no private practice in the Netherlands, so it's a dedication within your team, because it's not only the operation that people can like, but you also need to care for sick people.
Okay.
And that's already a selection.
And Christoph, you seem to have more of a
So we do almost all in Oslo, and there's 3 of us, always 2 of us present, and only 3 of us doing the Highlanders.
Okay. Now,
If I may
please.
add, because
Sorry, Hans.
what Stephen didn't mention is that the system we introduced in the Netherlands is actually a doctor's chosen system that we say we cannot operate if we are not experienced. So the surgeons among them each other, they decided which centers will do the operation and which won't, and the insurance company won't pay if it's not in a center. So that is a system which is given by the doctors themselves. So maybe you get together and decide yourself amongst in all the countries. I mean, we've done it, so why don't you?
Jahid, are you convinced by the panel's view? As you know, we have tried to have centre
Not at all.
specialisation in the UK, and it dismally failed. There was
Yes.
absolutely no UK support for centralisation of service when I tried to promote it. So it's interesting to suggest that perhaps things have changed. Perhaps we'll come back to that. Thank you very much for the question. John, we are going to move to a different topic, but if you have a specific question, please, we will address it.
It's actually a very similar question to that which Shahid asked. The centralisation of difficult things to do globally appears to have been achieved in the Netherlands and Norway. In the Netherlands, the absence of private practice, I imagine, has an impact. But in Norway, you appear to have just done it, although you did, in fact, mention at one stage the police. How were you able? How did you do it? Is it a guideline? Is it a sort of political process? How did you do it?
It's actually strange because it was not much of a problem in this case. It has been a lot of struggle for rectal cancer surgery and other types of surgery, but this for HPV cancers, it went rather smoothly, surprisingly, because what we know in Scandinavia is that the Swedes and the Finns, they do as they're told, and the Norwegians don't. But it has worked.
Okay, thank you very much. We're keen to cover the topic of transplantation in the last few minutes of the session, particularly as this may not be covered in person in the other sessions of the talk. And as the UK is on the cusp of launching the emphatic study, and we're on the cusp of enrolling our patients with hyalocholangio into transplant, we're quite keen to learn from the Norwegian experience, who've obviously been going through this for a couple of years. So my question, just to kick this off, might be particularly about patients going through neoadjuvant treatment prior to transplantation, the geography of Norway. What's been your attrition rate of patients who've enrolled in the trial and actually getting to transplant, and how's the patient experience been of transplant for Hyla?
So my colleague Shiraz Yacoub, who made the 2 slides I showed you, he published a research letter in the BJS just 2 months ago, I think, with most of these details. I don't have all the particulars in my head, but the problem is that once you start to discuss transplant, the word runs around the coast at lightning speed, and everybody is talking about the transplant. Not only for colorectal metastasis, which is also a very, very, very narrow access to transplant, but the first thing the patients ask when they come is, can I get a transplant? And we know that the situation, the chance of getting a transplant is very, very, very little. So that's the problem, how we kind of inform about this in a sober way while not raising expectations too high. So for instance, for the first one, for intrahepatic cholangiocarcinoma, it's been there for 5 years. It's 1 patient each year of the 100 new cases each year. So it's a difficult thing to inform in a sober way.
Okay, can we have some questions from the audience related to transplantation? And while we're waiting for people to consider the issues, perhaps we could get the other panellists to comment on how their centre would perceive the situation regarding transplantation and also transplantation-related trials, because we know technically you can do it. So really the question is, how do you identify who should have the transplant and when is it going to produce good outcomes? That's really the crux. Steve, do you want to you want to take that first about the Netherlands or Heinz?
Well, we introduced at the MDT that there is a question, candidate for transplant or not. It's the standard question at the MDT. And of course, in most cases, it's a no. But if it's a yes, then we have a clear procedure which has been established by the 3 centers for liver transplantations, what the next steps are. So there is a clear protocol about that if the question is yes.
And do you have a national review group? That's
Yes.
obviously what's inherent
Yes.
in the system in
I don't
the
tell
UK
you what
at
the
moment.
abbreviation of that is because you will laugh out loud. That's the abbreviation. But we have that in place.
Okay, John?
So, we are not a transplant centre, and we work, as you know, with Cambridge, and we've had joint meetings with them to discuss this. I'm not entirely happy with the current UK protocols. I think the number that we're likely to transplant based on them is, I think, very low, and I think we do need to have more discussion about it. I mean, for instance, I've got a patient that would be suitable for transplantation with Peri-Hilo disease, but in the currently proposed protocol, if you've even sniffed chemotherapy before you're referred, you're out.
So John's alluding to the fact that the UK model for transplantation for cancer is a very, very conservative approach, because there is concern about making sure that we don't offer transplantation for people that are not suited or won't benefit from it. So it's a conservative approach based on historical data.
Indeed. Maybe slightly too conservative.
Yeah.
But
Adipa?
For transplantation.
Transplantation?
In my institute.
Or in Thailand?
Also in Thailand. Cholangiocarcinoma is relative contraindication for transplantation because most of our cases, cholangiocarcinoma occur in non-cirrhotic patients. And the indication for transplantation is small mass, no extrahepatic metastasis, no lymph node metastasis. Almost all of that we go to surgery upfront. So,
I think you're alluding to one of the concerns about the question of whether or not one person's resectable disease would be somebody else's transplant recipient. So, Rachel, do you want to comment on that?
I mean, we have had data for a long time to show that there are some small number of patients that will benefit, and I guess the question, as you say, Brian, is how we get there and what the neoadjuvant pathway looks like and who we're going to be operating at the end of it. As they're probably, I think, only transplanter on the panel, I'd be quite interested in your view about the proposed protocol and whether you think that's going to be selecting patients suitably.
So I haven't been personally involved with developing the UK protocol for the cholangiocarcinomas, but my overall observation is that yes, technically we can do this. So what we have to do is identify a system for evaluating who's going to benefit, and that's the problem. We haven't got those systems. What we've got is historical data for some patient groups that have been transplanted that have done well, and some groups that have done very badly. But really, this is very poor quality data, very poor quality science, and my thoughts are that the prospect of evaluation should be at least cohort studies where everybody's being evaluated properly, and there should be genotyping of all the cancers. It seems to be that is where we are scientifically, and yet we're not there with the transplantation assessment protocols.
Can I just ask, is your transplantation protocol in the UK based on Mayo? So I just worked in Toronto for 7 years where we did a lot of transplantation, and in Ireland as well, for Peri-Hilos, but also for intrahepatic cholangiocarcinomas beyond the 3 centimetres. And I very much agree with your point. For intrahepatics, absolutely, there are some patients who can benefit from liver transplantation. I strongly believe they're based again on these liver confined patients that we genotypically may be able to define, but they self-select. The struggle with intrahepatics right now is the moving field of immune checkpoint inhibitors and how we deliver that neoadjuvantly in the context of transplantation. But in Peri-Hilos, is it based on Mayo, your UK protocol?
Yeah, so based on Mayo, but modified in particular, so the brachytherapy has been replaced by proton beam.
Yeah, I struggle with Mayo a lot in patients with some of the perihylers that we're giving, the chemoradiation therapy to first, especially in PSC patients, drainage, all the rest, and some of these patients can drop out, and sometimes I feel we limit their systemic therapy. So in Toronto, our dropout rates were extremely high. I don't know if anyone else has had Mayo problems.
Okay, thank you very much for that comment. Yeah, the controversy has very much been round about the appropriateness in hyalocholangiocarcinoma and following or not following Mayo. I think there's quite good consensus on the small peripheral intrahepatic cholangiocarcinomas in severely cirrhotic patients, which is the patient cohort historically which have done extremely well with transplantation.
But there's only one been transplanted in the UK by those criteria ever.
Exactly.
Okay, so thank you very much to all the panel for joining us, Christopher Larson, Stephen Older-Damick, John Primrose, and Athol Tipperwin. We're very grateful for your input today. Thanks so much.